Thank you for being here. I'm going to be focusing on a clinical decision support aspect of documentation implementations. It is definitely applicable to all areas of your implementations. What I just want to say, though, is I really like interaction. So, and I can barely see you people that are really far away. So if you want to move down a little bit, that would be helpful. And I also want to explain a little bit. Workflow engine is really a term that the Siemens product, Soaring, uses for their alert system. And so it is very confusing, and you have to be careful with confusing that with workflow processes. And so I'm going to try to stay away from the workflow engine terminology as much as I can, but I do slip up every now and then. And they also call any kind of clinical decision support alerts. So I'll use that word a lot in my presentation. How many, I just want to get an idea of what kind of I know I can't get those that are on the phone, but how many clinicians are in the room? How many IT people?
And that would mostly be Wanamaker.
That would be mostly be Wanamaker, okay. Is there anyone that is on the clinical decision support decisions? Okay. I have done multiple roles at Mainline Health. I have had the opportunity to be, I was in neonatology for the first 25 years of my nursing career, and then became very interested in informatics. So then I was the system administrator for a neonatal system, and I've also been a clinical analyst and also an analyst in IS, and now I work for information services. And so and then plus the working with clinical decision support gives you the opportunity to work and touch a lot of areas. So I've had a lot of experience with the multiple areas and the different clinicians, because we provide alerts for all sorts of clinicians. I just wanted to say that I am an employee. I don't have anything to disclose. I don't have any financial connections to Siemens or their product. I am an employee of Mainline Health. I'll be mentioning some of our stuff later on when we do an evaluation. The objectives for today are to discuss 2 best practices when implementing clinical decision support. So we are going to look at some best practices in the literature. We're also going to look at a CDS model that I developed based on the literature and based on our experiences. So we'd like you to discuss one aspect of that. CDS is the acronym for clinical decision support. So we're going to discuss one aspect of the CDS model that applies to a current project of your own, either pre or post implementation. Our examples will focus on post-implementation, but they certainly apply to pre and your design and all of that. And then state one question to consider when evaluating implementation effectiveness. So clinical decision support is taking the electronic health record and providing information that, combining information and putting it in one place at the point of care. Preferably at the point of care. That's the ideal. So if I am on a certain drug from this system and my lab value comes back X, and that's a concern that maybe you want to lower the dose or stop the dose, that kind of thing is what clinical decision support is, getting the information from different pieces of the system and kind of throwing them in the face of the clinician. So what I really, the way we are arranged, I don't really, can't really be as interactive as I would like, as I normally like, but I want you to think in your heads, just start thinking right up front, what have you implemented, and what challenges, specifically system limitations, have kind of caused roadblocks. But we do learn from that, so think about what you've learned and what questions you might go through your mind when designing or evaluating or meeting up with the user, so you have a request. What is it that you want to do with that? And these are some of the questions that we're going to look at and investigate in literature and just see what their recommendations are. So our little roller coaster ride down the EHR, or electronic health record, kind of started getting a little faster in 2001 when the Institute of Medicine recommended closing the gap of that quality gap in healthcare systems, and to really we need to start using the electronic health record. We need to start utilizing what they do in the business world and connecting all the dots and using that. But they did recognize, as quoted here, the challenges of applying information technology should not be underestimated. Healthcare is undoubtedly one of the most, if not the most, complex sectors of the economy. No kidding, right? I mean, it's hard stuff. And as we get more and more into our implementations, we can kind of see that it is very, very challenging. So we just fast forward to 2009, and with the American Recovery and Reinvestment Act, the government's demanding meaningful use. And specific to clinical decision support, one of the goals is to apply CDS at the point of care. And the ultimate goal being, of course, to capture that information and to report it, that health information, to be able to track any kind of key clinical conditions. And so that's the ultimate goal of what we're doing. It's not just the goal of clinical decision support, it's our goal of clinical documentation and CPOE and getting all that together in one kind of big happy family. So my first little look at the literature kind of was leaning towards more of an alert fatigue kind of thing. I don't know, do you guys use a lot, are you guys to the point of using the rule? Is everyone from CHOP here, or are there some HUP people? Are there any HUP? Do you use any clinical decision support at all?
Some.
Okay. The first quote is, "Too many alerts lead to automatic overrides by clinicians, and too few may fail to prevent what could be preventable errors." So we want to balance. We don't, and I think this is a great opportunity if you only have a few to be able to start thinking ahead and thinking globally and maybe learn from some of our mistakes. And I'll be talking to you about what Mainline Health has implemented when we start going through the example. The National Institute for Healthcare Management Foundations says that excessive alerts and pop-up screens can be frustrating, slow down tasks, and lead to workarounds. And certainly that is not the intent. We don't want workarounds, but there are workarounds that happen all the time. And we have to be aware that that does happen. And then the Nursing Executive Center Best Practice Report suggests that we limit the quantity of alerts between 5 and 20. Now, I don't know how that, it wasn't defined specifically within this article what they mean by 5 to 20. So does that mean 5 to 20 types, or 5 to 20 per day or per user? It's kind of ill-defined. And then Information Week and HiSong suggest to avoid alerts that are not absolutely necessary. So we want to make sure we're really careful what we're selecting. I know initially when you're you get into it, and it's so exciting, and we want to just do it all, because it's such a neat tool. But we have to remember that it's just, we have to remember to keep the scales balanced. Here's some of the other things that I want to go through that's in the literature. We want to make sure that we use best practice, and I think the first one I would look at is obtain consensus. And you think it's really difficult, because I know that you guys have subcommittees, like technical subcommittees or unit councils, and usually your technical groups tend to be more technically savvy. It's just the way people radiate. And so when you get your clinicians some of the clinicians that aren't so savvy involved, Sometimes they have a different opinion. So if you can have a little bit of a balance, I mean, it's not an easy balance to achieve, but you just want to make sure that you obtain consensus from all the stakeholders, because the quality director is going to have a different perspective than the user. So you just want to make sure you include all those people. You want to have clear design, and we've had some problems with putting things out there that we think make total sense. And then they're like, well, that doesn't make sense to me. I don't even know what you're talking about. So that's another place you can bring in an end user and say, out of the blue, not someone that has been planning, because they're hearing this over and over again. Let's do this. Oh, no, let's do this. And you go down the line and everybody's happy, but then you throw it to a new person and I have no idea what you mean. So make sure you have clear design. You want the correct target audience. I love it when nurses ask for the physicians to be alerted and the physicians ask the nurses to be alerted. And people do that all the time because in their head, it's the other person's responsibility. Well, you got to make sure the other person thinks it's their responsibility, or you're going to get into some kind of trouble. So you want to make sure you have the right audience and the right person, that it fits into their workflow, which we'll get into about that. We want to make sure that we create efficiency. And we're not making, now, understand that in the, clicks are inevitable. In an electronic record, you can't just say, I can't click. And I know that there's even research out there that people have counted the number of clicks it takes to get to a certain point. And, it is frustrating, but there's going to be some clicks. But let's try to streamline what they're doing and prevent as much. Wait a minute, I have to go here and here and here, instead of trying to, fit it. You want to fit it into their processes and be as efficient as possible. You also want to bring value to the user. So what's in it for me? And if you can explain that this is why, or, it's an infection control, or a core joint commission, core measure, whatever measure that you can explain to them, maybe they'll be like, okay, I'll buy it, because they really need to understand. Otherwise, I've heard, it kills me because I am the project manager for the alert team, so it kind of kills me when they're like, well, we ignore alerts, and I'm like, well, okay, and that sounds. If you haven't implemented too many, that sounds like, well, how could that be? How could they ignore them? They just need to do their job. It's not like that. It's just that you're so overloaded at the bedside, and they just get frustrated. And you get one alert that is maybe not done quite correctly, or not quite up to snuff, and then they're like, they're all no good. And so you just do your homework and be as careful as you can, the integration into workflow, we've had several, and you'll see when I talk about Mainline Health and one of the examples we have out there, that integration is really important for it to really work, to be effective, essentially. You want to watch your speed of installation. Otherwise, you're going to just overload the head, the brain, and the brain can only intake so much information before it just spills out the other side. So, just be careful how fast you're going. And I remember going out and doing some education for a particular alert that was going out there, and it was a subgroup of people, but they just looked at me and said, we get something new every week. Every weekend we come in, we have something new, and it's such a challenge because they're trying to do the patient care, and then they're getting overloaded that way. And then, of course, you want it to figure out how to be useful. Now, I'm a very practical person, and I understand that a lot of these things can be a challenge, especially with any kind of system limitations or anything like that. Here's a few additional considerations that I thought were interesting. Address issues that are not related to documentation compliance and timeliness. So if you're missing some piece of documentation that's just not being done, the advisory board company is saying, that's really a process issue, and that is not a thing to address with the electronic record. And we have been actually guilty of that several times, and sometimes I think it's just out of desperate. The regulatory person is under this pressure. Joint Commission, we just did a mock survey. Joint Commission saying, this isn't right. How can we fix it? Well, then we can do an automatic order, or we can pop up an alert, and it really is a documentation issue. You know, the recommendation is to try not to do that. I think there's some times where we have to do that. I mean, and so, you know, there has to be a give and take. Is there an alternative method to bring about compliance? And if you guys can, I mean, if you can take hold onto this is really something that I recommend you have in your pre-design. Just say, look, before we say, yeah, we're moving forward, we're going to do this, let's, this is exciting, and that's just, really, is there another way that might be better, or just, might not use an alert, which we should limit. And then Chester County Hospital has a rule of thumb, and they say that, tell me something that I don't already know. So, tell me, I go into a patient, and I go into their record, and I know what I'm looking for. I'm smart, I'm a clinician. Don't tell me something I already know, because that's just a waste of my time. But then you get into that difficult thing of whether you're a novice or an expert. And so the novice person might need that information. And so it gets to be very complex with our decisions. So I want to go now step into the CDS model, clinical decision support model, that I created. And it is, pre-design is critical, and I've commented on that several times. And then there's the design, the actual design stage. I have a few comments on, and the post-implementation, such as evaluation and metrics. So at the very cornerstone foundation, the very bottom here, I have the pre-design, and the first thing is you really want to integrate the process, and I know I've said that, and I'll probably say it a zillion more times. But the other part of that is the policy, because the policies sometimes might have to be adjusted slightly, and not only the policy, but their workflow processes might not fit quite the way the electronic. I mean, sometimes fitting that electronic piece is like putting a round, what is it, a round peg in a square hole. I mean, you really have to be creative in figuring out how to get that integration going, and so it's a challenge. I mean, and along with that, if you understand system limitations right up front, you'll in that pre-design, and you're just starting to talk, and you're pulling your groups together, it's really helpful to know what those limitations are. I know that I personally have been guilty of, I'm not sure, because clinicians come up with fabulous ideas, and it's like, I haven't heard that one before. I wonder if we could do that. If at all possible, prep as much as you know about that system, and say, well, that's not possible. We could do it this way, and then you're cutting your design. We really want to we don't have a whole lot of time. We're trying to get these implementations done, and we want to make sure we do our homework and understand all that. One thing that sometimes is missing is that clinical ownership, and what I mean by that is in relation to the metrics. So we do all these we do these designs, and the actual we prepare what the report will be. What do you want to measure? How are we going to improve it? But if you don't have a clinical owner, then when you're doing follow-up, there's no one really looking at those reports. It's almost like the IT person, is kind of pushing it out there, which they're the ones that really need to own this. It's their patients, it's their improvement in patient safety. So I recommend getting that clinical owner up front. And then, of course, because we want to limit the alerts that we put out there, we want to make sure we have a knowledge of all the quality initiatives, because you might want to kind of zero on them first, and then maybe do other things after that. And then the design and education. Now, this was not meant as a system life cycle. So I didn't include testing in here. I didn't include a lot of those processes that are in there. But I was particularly focusing on that clinical decision support. Of course, of course, there is a testing phase and other things that happen. But the design and education, to me, really go hand in hand, and I'll go into that a little bit. And then, of course, your top piece is your evaluation metrics. I kind of already went over the pre-design, but your integration of process and policy, what I put under that is what the literature review said. So you want to understand current workflows, you want to bring value to the user, you want to create efficiencies, avoid documentation compliance issues, understand the necessity, you want to consider alternatives, appropriateness of the audience. I want all that in there, in that integration category. Communication, a ground level of what's possible and what's not, your clinical ownership, and then, of course, your knowledge of quality initiatives. We want to know what's important to patient care and what's important to the organization. So for your design and training category, you really, we need clarity. We talked about that. You want to be very efficient when you're delivering your message. One thing that worked really, really well for us when we could, sometimes if you can work it in your timelines, it's really great. But we try to do the actual, a little bit of the build as a final design review session. And that visual kind of turns a light bulb in a lot of people's heads. And I know there's not always resources to do that, but if that's possible, it really, I think it was our most positive experience because they got it. They understood, this is what you're talking about, instead of just theoretically, throwing out opinions. And then that information, and this is all important for your education too, because then you can kind of realize, well, where are there weaknesses in that whole process that maybe need to be emphasized, or a process change that might need to be emphasized. The information transfer, how are we going to get the word out there? It's really a challenge in healthcare because you have your weekend people, you have your part-time people, you have your per diems, and then you have off shift, and it's hard. We've done a lot of Captivate and PowerPoints, and I think they're awesome. But someone has to actually go to them and look at them, and so you're counting on the person to go look. And I don't think it's not always effective, if I'm going to be honest. I think that sometimes either that, or they're not very clear, or they don't understand it, or they've read it and understood it. They've even gone to class, but they didn't retain it. I think I've heard it takes 10 times of repeating on average for someone to actually retain something. So we can't say just because you've been to class that you really, really understand it and know it. And then to watch the speed of implementation. So for the evaluation stage, I kind of divided it out into 3 areas. If you're going to base an alert and its effectiveness and whether it was successful in doing whatever you intended it to do, you have to kind of prove that they're actually using it, if you can. Obviously, if they're not using it, it's not helping with anything. And so you want to look at your utilization metrics and just be really careful with that information because you don't want to make too many assumptions. Oh, well, they're not doing their job, or they're not, there might be a really good reason why they're not using it. And so you need to really figure it out. We'll talk about that when I get to the example. But you want to explore all the factors that contribute to whatever improvement or not improvement was made. And then, of course, you want to, we really have to ask about patient care metrics. Sometimes putting something from paper to electronic doesn't mean it's going to improve the way care is given. And so we've got to remember that. But at a minimum, at least we have an electronic baseline where we can now, from the record, monitor from here and see how effective have we been. And then efficiency metrics if applicable. So I don't know how it's done here at CHOP, but we do a lot of quality initiatives where the nurses actually go in and pick from the chart in order to see if certain indicators were met and do a similar thing. It's really, if you can do a report and streamline the data process, you can really save them some time. So now I'm going to go into an evaluation example. Let me just explain a little bit about Mainline Health. We have 4 acute hospitals. 3 of the acutes, and we also have a rehab facility. So 3 of the acutes and the rehab facility use the Soaring Application, and Riddle uses Cerner. And so for purposes of this evaluation and Soaring, this is talking about the Soaring, the 3 acute hospitals. And we have implemented, let's see, I think it's 4 or 5 years ago, medication barcode system. And then like 3 years ago, we started with clinical documentation, and then 2 years ago with CPOE. So we've done a lot, but there's a lot more to go. We haven't done emergency room, OR modules. But because of that, we've put a lot out there as far as alerts go. And starting sort of March, April, there was a real scream for there are just too many. So we actually took a step back, our team, and started doing rounding and finding out exactly what the issues were with any particular alert. And so we started out with the physicians, and they were actually very helpful in helping us to refine some of the way that the logic was. And nursing, when they were screaming alert fatigue, we thought, well, you know what, let's go with, let's find out the quantity first. Let's see what the, because anyone can say there's too many, but let's see how many there really are. And we have councils, like you have like unit councils. We have a physician tech council and also a nursing similar technical council that makes these decisions. And so that these are the teams that we would take all these, this is what's been said, what do you think, and what can we do to improve it. You also want to make sure that you contact all the stakeholders, because I might be saying take it away because it's not useful to me. Well, why was that done in the first place? Is it a Joint Commission thing? Is it an infection control thing? Let's figure it out. And then the alert utilization I talked about and evaluation. Let's see if they're actually using the alerts and dig very deep and don't just assume. And then the last thing is decisions to remove are not as easy as it looks. And I will be touching on that also. I should say take a deep breath before you look at these numbers, if you can even see them. We had 39,738 total alerts issued in the month of June 2011, and that was for nursing only. So we were a bit blown away by that, and that is a lot of alerts. And some of them are because they're reissued, the next interesting thing is that 33,000 of them were infection control related, and that is 84% of all the alerts. So this shows, the graph just shows the numbers in the different facilities. You can see they weren't too worried about the lower ones. They really wanted to keep most of those. The first 4, port access, needle changes due, patient put in isolation, any MRSA related, get a MRSA swab for the nursing home patient. And anything isolation related they wanted to keep. But then the last 4, it's actually the first one and the last 4, central line dressing changes due, central line cap changes due, peripheral IV is due to be changed every 72 hours, and then Foley has been in for 48 hours, it's due for a change. So we're like, yeah, we need to get rid of them. Nursing council said we need to get rid of them. I'm like, whoa, let's hold up. We've got to investigate with infection control because they're the ones that asked for it. So we did. And infection control's initial response, I said, look, we've implemented these, started implementing them in 2008. They're screaming they want to get rid of some. What can we do? And at first they're like, no, we can't get rid of any. We've done a lot of initiatives. How can we say that the alert wasn't effective? I mean, they had put in VAP bundle. They had put in, all these extra Foley care, a CAUTI, they call it the CAUTI team for UTI and infection kind of. All these teams have been working on this, and alerts was one of them. We can't get rid of them. But then when I showed her the numbers, she's like, okay, I see what you're saying. And so infection control kind of agreed that, yeah, this sounds like the smart thing to do. The numbers are kind of telling us what we need to do. So before I show you the next numbers, which are a little bit of an ouch also, at least on first look, I wanted to show you a little bit what the Soaring Application does with alerts. So if you can see, this is an example of a peripheral IV changes due. And I circled the little arrow because that is what we call a suggested action. So there's an action you can take. You can click on that arrow, and then it goes right to the documentation where you can change, put how you changed it and do your documentation right then and there. We thought that was fantastic. Hook to the assessment, and wow, that's awesome. So take a deep breath. This data actually shows you how many people actually used that suggested action arrow. And the blue, unfortunately, is that they didn't touch the alert. The dark maroonish color is, or the reddish, is actually they hit the minus sign, which really doesn't do anything. And actually, if they haven't valued the dates correctly, it will reissue. So that reissue, it was part of the higher volume of alerts also. The yellow means they did select the suggested action, and there's like 3 for the Foleys, it was 17 for the cap change. So, and interesting enough, for port access, for some reason they were using it. So I'm relatively using it. Now, I really think that graph tells a story. But I think we really have to be careful that we're not making assumptions. We actually took this graph back to the council. And I asked a few people before council because I kind of wanted to get an idea of what was going to happen, whether we were going to explode in the meeting or what was going to happen. So I said, what's going on? And she said, it's because the alerts are issued at 7 in the morning. And I look at them when I'm getting a report. But I'm not doing my shift assessment, and I'm not ready to document because I haven't even changed my IV yet. And so essentially, and the way the alerts work in the Soaring Application is it's kind of a separate work list. So it's not the kind of pop-up that pops in your face when you're in the shift assessment. It's actually on a separate work list. It's almost good for a handoff or something like that, rather than right in your face. And so what was really fascinating is they got a little defensive when we showed them this. And they said, oh, well, we're looking at them, but we're not using them to document. We're using them as a point of reference. And so, believe it or not, they started to do a little bit of a him and hawing, should we really get rid of it? And it's really, it's hard. And it's very, I don't know, enlightening. To me, that, when I looked at that, I thought, well, then we should just get rid of the alert. And that's, and not necessarily. How many people? So if there's 10% of you that actually use the alert, should I get rid of it? I mean, it becomes this ethical kind of like sway there that is really hard to make that decision. And we are getting there. I'll tell you the conclusions in a second. But we also recognized that there were other processes in place. They had asked for a daily rounding report. They do daily rounding, and it showed what patients had Foleys, which ones had the central lines, and they said, let's get used to that first. It had, like, just the week before, we had gone to the table about this. They had started using it. Let's see if we can get that established, and then maybe we'll be willing to get rid of one. So that it's still kind of an ongoing debate here. But there's also questions to consider. So I want you to remember that we want to evaluate everything we've put out there. We just don't want to assume anything. We're putting stuff out there. We feel a little pressure to get stuff out there quickly. Let's remember to pause every now and then and evaluate what we've done and see, what's working and what's not. So I explain. So explain the process to me. You're the user. Explain how this works in relation to the way the alert is designed. And how does that alert system design assist or detract from effectiveness? So we had a little issue with it's sort of on a separate work list. It can help remind me it's not helping me. So, and if it's going to detract, then maybe we can use a different. Maybe we won't use that particular process for an alert. And also, who was the driver? So infection control in this case, you don't want to exclude them. You can't just say, okay, we took it to council, they say get rid of it, it's gone. Make sure the stakeholders, all the stakeholders know. And that's all, that's everyone. That can be, from a very high level to the user level. So. And then know your quality initiatives. So if it was part of a quality initiative, you might be a little more hesitant. Maybe you want to redesign instead of just getting rid of everything completely. And then, of course, training. Sometimes re-education is needed. We did getting heparin into CPOE proved to be a very challenging thing to implement, and we actually didn't have great what we do is an alert that lets nursing say, look, I need a bolus based on, the protocol or the guidelines. And that message went to pharmacy, and pharmacy was complaining they weren't getting enough of those. And so that kind of type of alert utilization is really important. Like in the IV case, it's fine if it's a reminder, good, I'll change it. But in the case of a very high-risk med, then you really want them to utilize the alert. And so they said, this is the way we want to do it, but we need to re-educate and go at it again and get the word out there. So sometimes it is re-education. You don't have to change things around. And then the bottom line is, what are the measurements saying? And we've got to listen to them. So our conclusions were there was a lot of ambiguity. When is it appropriate to remove alerts? What factors contribute to safe removal? Not a whole lot in the literature about that, and I think it's worthwhile to start, diving into that. We did talk about redesigning the Foley, get rid of the alerts, and then in the clinical documentation, in the shift assessment, try to do something that kind of lets them know, look, it's been 48 hours. But that's a little bit, it's not as simple as it looks due to system limitations, and so we're going to have to I don't want to say jury rig, but you kind of have to, use a little creative magic in order to figure out a way to maybe do it where it's more in their workflow. Our current state is we're looking probably to remove the Foley alert, but everyone's chicken. But we'll probably remove one of the 5 alerts. 2 of those 5 alerts, interestingly enough, were IV team alerts, and nursing said, yeah, get rid of them. So what's the problem with that? It's not the IV team. So exactly. I mean, you can't just say, maybe they're using it. I mean, maybe they need it for a reminder or whatever. So in summary, I just want to go over just a couple things. You want to base your implementations on best practice. Let's select carefully and don't overload the user, I think is a very strong message here in the literature. Integrate into workflow processes, and that's easy. We can do Visios, and we can, or even if you don't have Visio, you can list all the steps that everybody takes from the user side. But sometimes your electronic system just does not quite fit into that, and so you need to look at every possible aspect and make policy changes if need be. Maybe they need to adapt their process a little bit, and then you need to have some flexibility there. You want a clear and concise message. Simple is better. Know your audience and their needs. It's really important to understand what exactly they're talking about. I know as a nurse, sometimes I feel like I'm speaking a little bit of a different language than IT people, and the users sometimes feel like they're totally in like another wavelength, and it's really important that we get our translator caps on and really understand what each other's saying. And part of that is really knowing your audience and understanding what they're going through. I can't emphasize enough how important pre-design is. If you do your homework up front, and do a lot of work to help guide the team into decisions, you really do save a lot of time. We did homework about their current workflow processes ahead of time and diagrammed it in that way. When you're talking in the group, you're not intaking that information, you're clarifying the information. This is what we understood. Tell us where we got it, maybe got it a little off, and that saves you a whole lot of time. That clinical owner of metrics, we found is very challenging sometimes because they're very busy, and so I think that's really key. And for measuring success, my phrase is no stone unturned. So you really can't make assumptions. We could have made assumptions with that, with the graph. Look at all that blue, man. You're not using the alerts. Let's get rid of them. And really, that's not what we want to do. We really want to. We want these implementations to be successful. And let's face it, everyone's learning. We have newer systems, you use Epic, and some use Cerner and Soaring and all those things, and they're not it's not an easy thing to put the electronic systems into healthcare, and we have to learn as we go and figure out, what we need to do. And sometimes it means going back and relooking at things and tweaking things, and that's our due diligence. So I think I've left enough time for questions. If anybody has some questions, I'd be happy to answer them.
Anyone in the audience have questions? There are microphones, or just raise your